Everyone, thank you for joining us today for a MarinHealth webinar on hip and shoulder care. Everyone is muted, but if you have any questions, you can submit them in the chat box. At the bottom of your screen, there is a speech bubble icon, and you can hit that to bring up the chat box, and feel free to ask questions at any point. If you have submitted a question when you registered, we have those already, and we'll address all of the questions at the end of the presentation. So we have two wonderful speakers today. Both are MarinHealth orthopedic surgeons. Dr. Eric Bava is going to start us out with a discussion of shoulder injuries, and then Dr. Michael Brown will follow up the presentation with a discussion of hip injuries. So I'll go ahead and pass it over to you, Dr. Bava. Take it away.
Oh, great, thank you so much. So yeah, I'm Eric Bava. I'm an orthopedic surgeon at MarinHealth. I do specialize in shoulder problems. And I was going to share a little presentation here. And so as far as the shoulder goes, the shoulder is a unique joint. One of the key things with the shoulder is that it has a large amount of range of motion. It's got the greatest range of motion of any of the joints in the body. And oftentimes we think of the shoulder as a ball and socket joint. In reality, there's actually two joints about the shoulder. One joint is actually where the ball and socket are. The ball is the humerus, and then the socket is part of the shoulder blade, the scapula. But there's also a small little joint in the shoulder as well that we call the AC joint, and that's where the collarbone, the clavicle, meets the shoulder blade. So these are the bones of the shoulder: the humerus, which is the long bone of the arm, the scapula or the shoulder blade, and the clavicle, the collarbone. In addition to the bones, some of the other key structures in the shoulder are some of the muscles, and probably the most talked about or thought about muscles of the shoulder are the rotator cuff muscles. And there's actually four muscles that comprise the rotator cuff. Those muscles are the supraspinatus, the infraspinatus, the subscapularis, and the teres minor. And the reason why we call the rotator cuff a cuff is because those four muscles, they start off on the shoulder blade. They then come together, and their tendinous attachments come together and form this cuff that then surrounds the ball and socket joint, and they attach on the arm bone, on the humerus. And oftentimes when we talk about the rotator cuff tearing, we talk about that tendon of the rotator cuff tearing from the bone of the humerus. So what are some of the common shoulder complaints that people describe? Well, one of the biggest issues that people have with their shoulders, they have pain. And when is it that we feel this pain? Well, the pain is with reaching, especially with reaching overhead, reaching away from your body, sometimes reaching behind your back. And one of the other times that people are really bothered by shoulder pain is with sleeping. So by sleeping on your side, oftentimes when you roll over on your side, this causes pain in the shoulder. This wakes people up. And this is one of the more common complaints and one of the most common reasons why people come to see us for shoulder issues. In addition to pain, some of the other problems that we talk about or that we hear about is stiffness. And what we mean by that is that we're not able to reach as far as we used to. So instead of having all that range of motion that the shoulder once had, if it gets stiff, we aren't able to reach all the way. And lastly, one of the other complaints people will talk about is weakness. So that's oftentimes described as not being able to carry the heavier weight out away from their body. So people will talk about having difficulty with reaching into the refrigerator and grabbing that gallon of milk and holding it out away from their body because it just feels so heavy. So those are some of the common complaints that we hear about. What are some of the common problems that we associate with these complaints? Well, oftentimes we will hear about impingement. Now, what is impingement? Well, impingement is when this bone of the shoulder blade, it's called the acromion. These bone spurs will start to form, and they start to then press downward onto the rotator cuff as well as the bursa. And that impinges upon those tissues that are below this bone. So we call it subacromial impingement. And what happens with that is we start to get inflammation in the bursa, which can cause pain. But in addition to impingement, one of the other problems that we see is rotator cuff tears. And a rotator cuff tear is, like I described earlier, that's when this muscle of the rotator cuff actually tears from the bone of the humerus. And when that happens, when the muscle tears off the bone, it's no longer attached to the bone. And therefore, those muscles are no longer actually working because they're no longer attached to the bone. And because of that, that oftentimes leads to the weakness that we talked about previously. Other problems that we also associate with the shoulder, these two problems are both oftentimes associated with more of the stiffness. So one problem, frozen shoulder, what happens with frozen shoulder, we also call it frozen shoulder adhesive capsulitis. We get inflammation in the lining of the shoulder joint. After that inflammation occurs, we then get scar tissue or thickening of the joint capsule or adhesions, and this then starts to cause it to be more difficult for us to actually move the ball and socket joint. So when frozen shoulder occurs, we then no longer have the same motion that we once had. And then lastly, one of the things that we also see in the shoulder is arthritis. Now, arthritis can happen in two different joints that I talked about earlier. Sometimes the arthritis is in the ball and socket joint. When arthritis occurs, what happens is our cartilage wears down. And when our cartilage wears down, our bodies don't grow back. So if that cartilage wears down in the ball and socket joint, we start to get some bone on bone in that joint. And if that's the case, we start to get some stiffness from that as well as pain because those two bones are not moving quite as much as they used to. But the other joint where we can also get some arthritis is up at the top, again, at that collarbone, where the collarbone meets the shoulder blade at the AC joint. There can be arthritis there, and that can also be a pain generator. So how do we diagnose some of these shoulder problems? Well, one of the key components is going to be a physical examination. So when we are examining a patient, we are looking for how much range of motion or how much the shoulder moves. We're also looking to see how strong the muscles are. Those key findings can help us figure out if one of these problems is going on or other problems as well. There's various different signs and exams that we will do to try to figure out what the problem may be. But in addition to that, we'll also get x-rays. X-rays can be helpful for shoulder problems because they show us the bones. So if arthritis, for instance, is an issue, we can see that on an x-ray. For instance, this shoulder here, where the collarbone meets the shoulder blade, this AC joint has arthritis. There is actually less joint space there. There's some arthritis in that joint. But we would also be able to see if there's arthritis in the ball and socket joint as well. That's something that would show up on x-ray. But sometimes x-rays and physical examination are not enough to give us the entire story. And that's when we start to think about advanced imaging techniques. The most common that we probably obtain is an MRI. The reason to obtain these images is not to show us the bones, but oftentimes it's more to show us the soft tissues that are around the bones, the muscles, the rotator cuff, for instance. We cannot see that on an x-ray, but we can see that on an MRI. We can see that on ultrasound. So sometimes we're getting those tests to take a look at those structures. What are some of the treatments? So oftentimes we would initially try to treat shoulder problems with non-operative treatments. And the non-operative treatments for the shoulder are usually going to be these three general categories. Anti-inflammatory medications. So that may be as simple as just an anti-inflammatory pill, Aleve or Advil. Those medications can help decrease the inflammation. Because oftentimes, like in frozen shoulder, the underlying problem is inflammation. If we can bring that inflammation down, we could potentially get it under control with an anti-inflammatory. Physical therapy is going to also help with some of these problems because they're going to not only work on stretching the shoulder back out, but it also helps to work on strengthening up some of the different muscles about the shoulder that can help correct some of these problems that we have. And one of the last non-operative treatments that we would do is also an injection. So an injection could be, we call it cortisone injection, but it's a steroid injection to the shoulder. And a steroid is also a potent anti-inflammatory medication that we're putting into the shoulder itself. And by decreasing that inflammation, oftentimes that can be a good, effective treatment for some of these problems that we talk about. But sometimes the non-operative treatments do not seem to provide the relief that we need, and sometimes we are needing to go on to do a surgery. And in general, for these problems that we're talking about, I'd say there's two broad categories of surgeries. One category is arthroscopies, and one category that I'll get to in the next slide is replacements. For arthroscopies, oftentimes we are treating some of the most of these problems that we talked about. The arthritis at the AC joint can be treated with an arthroscopy because we can shave down some of the bone spurs. An arthroscopy is a minimally invasive surgery. It is done using a camera through tiny little poke holes in the skin. We can shave down some of the bone spurs. We can remove the inflamed tissue. We can remove scar tissue from the shoulder. But we can also repair a lot of the tears that we see in the soft tissues. So the rotator cuff, for instance, if it tears off the bone, we have the ability to put little screws into the bone that have sutures attached to them, and we can pass those sutures through this torn rotator cuff and sew it back into place when it tears. But another option sometimes is a replacement. And a shoulder replacement is sometimes what we're having to do, especially if there's arthritis in the ball and socket joint. Because when that happens, as I mentioned previously, when the cartilage wears down, our bodies do not grow it back. And then you have the bone grinding on the socket bone. And in order to correct that problem, oftentimes we're doing a replacement where we replace the ball and the socket with metal and plastic. Now, there's a couple of different types of shoulder replacements. There's a partial shoulder replacement, which means we're only replacing usually just the ball, but we're not replacing the socket. There's a total shoulder replacement where we're replacing both the ball and the socket. So in this picture, you can see there's a new metal ball and a plastic socket in their normal configuration. But then sometimes we're also needing to do what's called a reverse shoulder replacement, a reverse total shoulder. And the reason why this is called a reverse shoulder replacement is because, as you can see in this picture, the ball, the metal ball now, is actually attached to the socket bone, and the socket, the plastic socket, is actually now attached to the arm bone. And that's why it's called a reverse replacement, because we've actually put the ball on the socket and the socket on the arm bone. Now, we use this replacement for specific situations, but it's most helpful for when people have problems with both arthritis and tears in their rotator cuff. A conventional shoulder replacement usually needs a normal rotator cuff, but a reverse replacement can also work for people who have a non-functioning rotator cuff. Lastly, recovery and rehab after this. So for shoulder surgery, most patients would usually go home either the same day or the next day after the surgery. The arthroscopy surgeries almost always go home the same day. The replacement surgeries sometimes go home the same day or the next day after the surgery. Typically, your arm is going to be in a sling for a few weeks. The number of weeks would depend on what exactly is done during the surgery, but it would probably range anywhere from 2 to 6 weeks in a sling. In addition to the sling immobilization, you will then work with physical therapy. Physical therapy is going to focus initially on stretching or regaining all that range of motion of the shoulder. And after that's done, the next step would be strengthening in order to get those muscles strong like as they once were prior to injury. So typically for shoulder problems, depending on the problem, we would usually expect a full recovery within a few months. Some arthroscopy surgeries could be a full recovery could be seen within only 2 months. A replacement is probably closer to 4 to 6 months. But it varies depending on exactly what is being done during the surgery as far as how long it takes for a full recovery. Thank you. And
okay, Dr. Brown, we will pass it on over to you. Thanks, Dr. Bava.
All right, thank you. Are we up? Orthopedic surgeon, and can everyone hear me?
Yes, we're all set.
Okay, very good. Thank you. I I'm Michael Brown. I'm an orthopedic surgeon. I'm fellowship trained in joint replacement. My office is in Sonoma. I work in Sonoma and Marin County. I'm with MarinHealth. And today we're going to talk about hip pain diagnosis and treatment. And starting out with the hip anatomy, your hip is for mobility and stability. The hip moves in 3 planes of motion, front and back, side to side, internal, external rotation. It's a ball and socket joint, just like the shoulder. It is composed of the head of the femur and also the acetabulum. And the head of the femur is a cartilage covering head that is part of the longest and largest bone in your body. And that's the femur, and it makes up a joint with the acetabulum, which is part of the pelvis, and both sides of the joint are covered with a white cartilage or a hyaline cartilage, which is for cushioning. Symptoms of hip pain are when a person comes in to see me in the office, people will say, well, my hip hurts. And the hip could be in the thigh, groin, inside and outside the joint. It could also feel hip pain in the buttocks. And the symptoms, the hip pain can be felt in different locations. The most common cause of hip pain is osteoarthritis. You have an issue here in the hip joint where the ball and socket joint is normally covered with cartilage, the hyaline cartilage, and it wears down. And it wears down to bare bone, and then what you see is pain, and pain with ambulation. And classically, people will have stiffness and pain with weight bearing in hip osteoarthritis. The second, and a very common reason for people to come into the office with hip pain is bursitis. In the case with respect to the hip, the bursa is a sac on the outside of the hip located in the greater trochanter. The trochanter is a bone that's on the outside, not necessarily in the hip joint, but it's an area, it's a bump on the side of the hip, which we can all feel where we have 2 muscle layers that glide over that bone. And the bursa is a sac that we all have, but in cases of bursitis, it gets inflamed and the sac gets very inflamed. And most commonly, this can either be primary or secondary. In other words, it could be just due to overuse. It could be due to riding in the car, riding on an airplane for long periods of time, sitting with your knee flexed. Or it could be secondary to numerous other types of problems, such as hip arthritis, back issues, muscular issues, and what the secondary hip bursitis features as a gait abnormality. Now, hip fractures are another cause of hip pain, and this most commonly requires a person to go into the hospital emergency. This is an acute or an emergent problem. And these are just samples of different types of locations of hip fractures. They could either be in the neck, transcervical, subcapital, intertrochanteric, which is a little bit lower, but still considered a hip fracture, and subtrochanteric, which is a bit lower than that. Now, treatment of the transcervical or the neck fracture, if it is non-displaced, then typically that can be pinned. And as you can see, 3 pins are present across that. Now, if the fracture is displaced, then that can disrupt the normal blood supply. And if we tried to put it back and pin it, then it would be highly unlikely that that would heal. And therefore, for a displaced fracture, it usually requires a prosthesis, which means a stem that goes inside the canal of your femur and with a ball the same size of the femoral head, or in younger, more active people or people that have arthritis in the socket, it would require a total hip replacement. Now, for intertrochanteric fractures and subtrochanteric fractures, they're typically fixed Similarly, they could be fixed with, traditionally it's been a screw and a side plate, which would have the screw go across the fracture, either in the intertrochanteric or the subtrochanteric region. The newer techniques now call for putting a rod down inside the femur and with a screw that goes into the hole of the rod to help stabilize the fracture. And that's felt to be biomechanically a bit more advantageous. And that's currently the way we're treating those kind of fractures. Referred pain is a vast topic into itself. We could talk about that probably for 30, 40 minutes, but I will hit the high points. Referred pain in the hip. We'll start with one of the most common reasons, and that is people with disc problems. And a herniated disc in the lumbar spine could be material that's pressing on the nerve roots, in this case, the sciatic nerve roots that come down in your lower lumbar and the first part of your sacrum. And those nerve roots can actually go to the back of the hip, the lateral side, or the anterior aspect. And if you've got a pinched nerve, you can feel hip pain. If you've got arthritis, that is in the facet joints of your back, you can feel hip pain as well, just from the arthritis in the back, as well as you can feel hip pain from muscular issues such as the iliotibial band, which is the muscle down the lateral aspect of the hip, or the hip flexor muscles, in addition to naturally hip arthritis. The question is when to come to see one of us. I've just listed these as just as a guide. If you're having inability to walk comfortably, if you have an injury that causes joint deformity, now that would be something that would be more emergent. Inability to bend the hip or inability to bear weight, I think all those are really good reasons to consider coming in and have a diagnosis, being checked, examined, have a diagnosis, and be eventually treated for your hip pain. Signs of infection can include fever, redness, and warmth in the hip joint. However, they can not involve any of those, and a person with a hip joint infection can sometimes present only with hip pain and limitation of motion. But this is the type of an issue that may be very, very acute onset. In other words, come on rather suddenly. Diagnosis, as Dr. Bava has mentioned, X-ray is the gold standard. CT is a brilliant way to try to help diagnose fractures, to see if bones are broken or not. MRI looks for fractures and also to look for soft tissue injuries around the hip, as well as fluid collections, which may give you the idea that there possibly is an infection. Laboratory tests are vital if we're trying to test for infection, but it's also very helpful to help diagnose other causes of hip pain, such as rheumatoid arthritis or gout, and there are laboratory tests for that. Treatment, I think it begins with self-care at home, rest ice, compression and elevation, as well as gentle exercise. It starts with that. Non-steroidal anti-inflammatories such as ibuprofen and Aleve can help, especially in the arthritic complaints. Corticosteroid injections or cortisone are good anti-inflammatories, but they can also be a good looking for a diagnosis. A therapeutic trial, they're often referred to, because sometimes we don't know where your hip pain is coming from. And a cortisone injection can both be therapeutic, but it also can help locate the source of where your pain is. Physical therapy and surgery are also very, very helpful in terms of both the therapy, and then the surgery is the final result. Injections in the office. Well, bursal injections can be done in the office. and very commonly are done, and it involves injecting cortisone directly into the bursa to help shrink the bursa. It's an anti-inflammatory and can often give pain. You can also give pain relief, that is. You can also give injections into the hip joint, which are done under fluoroscopy, under an X-ray guidance, and they can give temporary relief for hip arthritis. Not permanent, but temporary relief. Physical therapy is very good to help diagnose hip pain. With people with arthritic pain, it's usually involved with flexibility exercises followed by low impact aerobics. If we're talking muscular pain, it would be stretching exercises followed by strengthening. And then, of course, with the back, it's helping to stretch out the back to try to help eliminate some of the key issues that are causing hip pain from the back. In terms of surgery, we've talked about hip fracture surgery. Most fractures of the hip will result in surgery. That is just a fact. And it most commonly requires patient coming in acutely, either to the office or to the emergency room. Total hip replacement, the anterior approach is a new advancement. Revision hip replacement is for pain and instability after a person has had a total hip replacement. And then arthroscopic labral repair is a repair of elastic tissue that is critical in hip stability. And that's usually in the younger people. People from their teens to their fourth or fifth decade are usually candidates for this. Prior to them getting arthritis, they may have a condition that would be treatable and curable with arthroscopic surgery. For the hip replacement, before arthritic hip, and then afterwards, you're putting in a new ball and socket joint. It's titanium. The head is either metal or it can be ceramic. And the cup is polyethylene lined, high density polyethylene, and both the cup and the stem are made out of titanium. This is just showing the lateral side of the hip, and the anterior approach is an incision that looks something like this. And an anterior approach is a very good approach, but it can give some early mobility improvement, but patient selection is very important. And then a revision total hip is done after a person has had a hip replacement and they're having pain, which could either be loosening or infection, or it could be unstable, that is frequent dislocations. That can lead to a revision hip replacement that is a bigger, more constrained implant that will give stability. The lifespan of total joint replacements for currently, our understanding is that for a standard total hip replacement is 20 to 25 years, and with a revision implant, we're seeing 10 to 15 years of a lifespan before problems could arise. And of course, what will the future hold? Well, we really don't know. Hopefully, these numbers will even improve in the future. Thank you very much for the opportunity to come to speak with you today. And as you can see, diagnosis is the key to the treatment of hip pain. And please consult your physician for any further information.
We do have questions that have come in. I know we're right about at our time. Dr. Brown and Dr. Bava, do you have just a couple more minutes to address some questions?
Absolutely.
Yes.
Well, we had one longevity of hip replacement, so you just hit on that. So our next one is, are there any supplements that can help with joint pain?
Well, I guess I'll start on that one. I don't know your thoughts on this, Mike, but the supplement that's probably the supplements that are probably talked about the most are usually going to be the glucosamine and chondroitin. These are things that are often available at the supplement stores as well as Costco and other places. It's something that may be beneficial. We don't have a whole lot of data that really shows that it is going to do that much to prevent arthritis. although some patients do find that there is benefit from taking them, a lot of the research that we have doesn't really show that it has prevented arthritis to much of a degree.
Yeah, I would agree with that. I don't think that that's, we haven't really been able to show. I think the efficacy is, it's anecdotal. The good things about whether glucosamine or turmeric or cumin or any of the other supplements is that they're relatively side effect free. And some people may turn to that initially.
Okay, so our next question is, for a hip with bone spurs, would stretching be a good thing or a bad thing? Would that help or hinder?
Well, I think that stretching is always a good idea. I think when you have hip arthritis, I think that some of the initial treatment for that would be to try to maintain or even possibly improve the flexibility of your hip, and that could only serve to try to help with the pain relief. So I think stretching could potentially be very beneficial.
This one's for Dr. Bava. For a mild rotator cuff injury or tear, do you recommend trying physical therapy as a first line of defense or go straight to surgery?
No, I think when we say mild rotator cuff tear, we probably mean something along the lines of what we call a partial thickness tear. And yeah, I think with that sort of an injury to the rotator cuff, usually we would start with physical therapy, maybe a steroid injection. That sort of injury, we would not go straight to surgery. We would try the non-operative treatments first. And if it does not get better with non-operative treatments, then we still may consider surgery at that point.
Great. Okay, and then just one final question that came in is for Dr. Brown, I think. My hip pops a lot, cracks a lot. Is that a bad thing, and could it be a sign of arthritis?
The answer is yes, it could be a sign of arthritis. It could also be a sign of bursitis, where sometimes you get at the hip and the lateral side. You know, hip pain has a lot of causes. There's also a condition called snapping hip syndrome, which will involve either the lateral muscles of your hip or the anterior muscles of your hip, and that can be in two different locations where people will feel like a snapping or a popping sensation. So I think if you had a doctor examine you, they would be able to tell you exactly what is causing that popping.
All right. Thank you so much, Dr. Brown and Dr. Bava, both of you for your time, and thanks to our attendees. We've recorded this and it will be up on YouTube in a few days on our MarinHealth YouTube channel if you want to share it with anyone else. Thanks, everyone, and have a great day.
Good. Thank you.
Thank you. Thanks very much.